Hello, everyone. My name is Margaret Messersmith, and I will be presenting my quality improvement project titled Implementation of Evidence-Based Treatment Guidelines for Upper Respiratory Infections in Urgent Care Settings. My project was completed with assistance of Dr. Jennifer Hopner, who is my DNP chair, Dr. Jennifer Theo, my second reader, and Winnie Shariwa, who is an APRN and my community member. Background and significance. The purpose is to implement CDC evidence-based guidelines for managing upper respiratory infections in urgent care settings. The aim is to reduce inappropriate antibiotic use, increase providers' knowledge and awareness of appropriate viral and bacterial URI management. What are upper respiratory infections? They are common illnesses such as acute bronchitis, sinusitis, acute pharyngitis, and acute upper respiratory infections. These illnesses are mostly viral and not responsive to antibiotic, making antibiotic treatments ineffective. Viral causes. These include influenza, coronavirus, rhinovirus, adenovirus, RSV, and parainfluenza, which are the most common viral sources. Prevalence. 80 to 90% of upper respiratory infection visits receive antibiotic prescriptions, and at least 30 of them, the prescriptions are unnecessary. Urgent care clinics have highest rate of inappropriate antibiotic prescribing compared to other outpatient settings. Significance. Antibiotic use leads to antibiotic resistance, increases risk of C. diff infection, allergic reaction or adverse reaction, and contributes to 2.8 million resistance infections and 35,000 deaths annually in the United States. Challenges in urgent care. These include high patient volume, patient pressure to prescribe antibiotics, and inconsistent provider practices contribute to inappropriate antibiotic use. Evidence-based guidelines. Implementing CDC outpatient guidelines help providers distinguish viral from bacterial infections and outline clear criteria for when antibiotics are appropriate. Benefits. Implementing CDC treatment guidelines standardizes care, reduces antibiotics misuse, improves clinical decision making among providers, enhances patient outcome, decreases complications, and strengthens long-term practice quality. Review of literature. Antibiotic misuse in upper respiratory infection is a critical public health issue. Most URIs are viral, but often treated with unnecessary antibiotics. Overprescription leads to increased healthcare costs, antibiotic resistance, and patient safety risk. Urgent care providers face pressures like high patient volume, patient expectations, and lack of standardized protocols. Despite existing CDC evidence-based guidelines, adherence in urgent care settings remain inconsistent. Systemic research between 2019 and 2024 identified 10 key studies focused on antibiotic overuse, guideline adherence, and interventions. Studies revealed high incidence of inappropriate antibiotic prescriptions, influenced by provider knowledge gaps and resource limitations. CDC and other authorities provide guidelines that, when followed, improve safe antibiotic prescribing. Provider education and clinical decision support tools significantly reduce inappropriate antibiotic use. Interventions like peer feedback, audit tool, and stewardship program enhance guidelines adherence. CDC outpatient stewardship framework emphasizes tracking, commitment, action, and education. Implementing evidence-based guidelines and interventions can improve prescribing pattern and patient outcome in urgent care. Method and design. Methodology. The Iowa model was chosen for its problem-solving practice approach. This included 5 steps: identify problems, form teams, select intervention, grade evidence, and evaluate and maintain change. Step 1. Identify clinical issue of overuse of antibiotics for viral URIs, causing resistance and higher cost. Form interdisciplinary team among urgent care providers. Staff leadership to collaborate for consistent practice. Step 3. Select evidence-based intervention, which is CDC guidelines to improve antibiotic prescribing. Step 4. Grade evidence involve assessing research quality, get expert feedback, address barriers before implementation. Step 5. Evaluate and maintain, include monitoring prescription pattern, ensure adherence, support ongoing improvement. Outcome: facilitate evidence translation into clinical practice, enhancing patients' outcome and safety. Method and design. Methodology. Quantitative quality improvement project using a retrospective chart review to evaluate antibiotic prescription pattern before and after CDC guidelines implementation. No direct engagement or procurement were involved. Data collection from patient EMR diagnosed with acute bronchitis, acute sinusitis, acute pharyngitis, and acute URIs. Educational intervention aimed to increase urgent care providers' knowledge and adherence to evidence-based antibiotic prescribing. Settings. This QI project was conducted at an urgent care clinic in Midwest United States. Healthcare providers included physicians, nurse practitioners, and physician assistants working in fast-paced urgent care environments. Sample. Convenience sample of 154 EMRs, including 77 pre-intervention between January 2025 through February 2025, and 77 post-intervention between March 2025 through July 2025. Inclusion criteria. Patients aged 18 years or older were diagnosed with acute respiratory infections. The exclusion criteria included anyone under 18 years old who was seen for URI symptoms. The sequential inclusion and exclusion process continued until suggested sample size of 154 EMRs was met. While gathering evidence, the appropriate steps were taken to protect the subject of the QI project and to prevent a breach of confidentiality beyond the minimal risk of breach of confidentiality. There was no suspected risk to the subject in the retrospective chart review. The researchers sought a waiver of authorization form to comply with the HIPAA privacy rule. Each EMR was assigned a numerical number on the data collection sheet, and the identified data was stored on a password-protected file on a password-protected computer. Access was limited to the researcher to comply with the HIPAA privacy rule. Data protection. Patient identifiers were removed to maintain confidentiality. The identified data was stored securely on a password-protected file, accessible only to the researcher. Simple. Figure 1. This illustrates the age distribution of the patients in the study. The average age was 41 years, ranging from 18 to 75 years old. As you can see in Figure 2, it shows the ethnic breakdown of the patient sample. The majority were Caucasians, followed by African Americans, Hispanic, and a small percentage categorized as other or unknown. Data analysis. A z-test for the difference of two proportions was conducted to evaluate the intervention's impact. A directional form of chi-square test. Antibiotic prescribing for URIs decreased from 65% to 33% after implementing CDC guidelines. The there was the z test of negative 2.75 and p-value of 0.003, showing a significant 22% reduction. The p-value of the 0.0030 is less than the significance level of 0.05. There is sufficient information to suggest a decrease in ratio from pre to post intervention. The confidence interval suggests a true change in ratio from pre to post intervention. 95% of confidence level for the difference in proportion of negative 0.374 to negative 0.067. Since 0 is not included with the interval, we have significant evidence to show a change in the direction. The statistical analysis revealed a significant difference between the two proportions, and hence indicating that intervention was associated with a significant decrease in inappropriate antibiotic prescription. The study had a strong statistical power of 0.87, which was really good, confirming an adequate sample size and reliable result. Provider education and guidelines used improved antibiotic stewardship and increased documentation and patient education on viral versus bacterial infection. Strong leadership, team work, and ongoing engagement help overcome workflow challenges and ensure successful implementation. The project demonstrates that targeted education can positively change prescribing behavior in urgent care settings. Results. The pre-intervention group demonstrated a higher prescribing rate of 61% compared to the post-intervention group, which showed a prescribing rate of 38% after the education implementation of the CDC guidelines. Current quality improvement successfully lowered antibiotic prescribing for acute URIs from 65 to 48% reduction post-intervention, consistent with positive national findings. These results reinforce the effectiveness of educational and feedback-based interventions in modifying provider behavior. Even in high-volume, time-pressure urgent care settings, this project demonstrates that community-based urgent care clinics can utilize affordable, flexible, and evidence-based strategies to enhance prescription of antibiotics. Limitations. The project was conducted in a single urgent care, limiting general liability to other settings. The sample size and short intervention period may not reflect long-term sustainability of behavior change. Without a control group, it's unclear if the intervention alone caused the improvement as others might have influenced prescribing. Measurement bias is possible due to reliance on provider documentation, which can vary in accuracy. Use of standardized CDC guidelines and leadership support help reduce some limitations. Lack of automated decision support means ongoing education and monitoring are needed for sustained adherence. Despite these limitations, the project showed promising results. Further research with larger multi-site samples and longer follow-up is recommended. Discussions. Findings. The project successfully used CDC guidelines to promote consistent evidence-based antibiotic prescribing. Strong teamwork and leadership fostered shared responsibility, ensured all staff understood their role in stewardship. Structured education and ongoing training improve provider knowledge, and encourage reflection on prescribing habits. Transparent before and after data collection showed clear reductions in inappropriate antibiotic interpretation. The project aimed to reduce inappropriate antibiotic use for acute URI by educating urgent care providers on CDC guidelines. Although antibiotic prescription decreased, the reduction was less than expected due to factors patient expectations, high patient volume, guidelines, variability, and documentation issues. Established patient-provider relationship may make clinicians hesitant to change prescribing to meet patients' needs. Provider education improved knowledge, but may not be enough to change behavior. Future steps could include chart audits, EMR integration of CDC tools. Stronger policies may be needed to improve provider adherence to treatment guidelines. Recommendations. Implementing CDC URI guidelines reduced unnecessary antibiotic prescription in the urgent care setting, showing clinically meaningful improvement. Future steps include more frequent provider training, adding EHR, and educating patients on viral versus bacterial infections to further decrease inappropriate antibiotic use. Implication for practice. Research. This project highlights the need for ongoing research and performance strategies to strengthen antibiotic stewardship in urgent care. Future work should evaluate instant prescribing alerts and different educational approaches for providers. Clinic can enhance stewardship by aligning protocols with CDC guidelines and conducting routine chart audits. Continued quality improvement efforts can further reduce inappropriate antibiotic prescribing. Healthcare policy. Results support policies requiring antibiotic stewardship programs in urgent care and outpatient clinics. Public reporting of prescribing metrics could improve adherence to CDC guidelines, strengthen policies, reduce antibiotic resistance, and promote consistent clinical practice. Quality and safety. Align prescribing with CDC guidelines reduce inappropriate antibiotic use and supported patient safety. Education and strong provider leadership collaboration fostered shared responsibility and sustained best practices. Meaningful behavior change occurred without each EHRE, electronic health record alert, showing the value of education and team-based approach. Evidence-based practicing, prescribing improved individual outcome and strengthen overall health. In conclusion, this project successfully reduced inappropriate antibiotic prescribing by implementing CDC guidelines and provider education, demonstrating meaningful improvement in urgent care antibiotic stewardship. The impact was positive. Greater change may have been possible with longer implementation, stronger policy support, and integrated EHR alerts. In the future, I plan to expand this work by joining my organization quality improvement team, to help with conducting routine chart audits in the urgent care and broaden projects to multiple urgent care sites within my organization and sustainability. This DMP journey has profoundly shaped me as a provider and a leader in my work environment and in my community. I've gained a deeper understanding of evidence-based practice, quality improvement, and the importance of system-level thinking. Most importantly, I have learned how to drive meaningful change, collaborate effectively with interdisciplinary team members within my organization, for safer, high-quality patient care. This project and the DMP program has equipped me with skills and confidence to continue improving in healthcare outcomes in my community. Thank you. And let me know if you have